Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon and welcome to VITALS, Visionary Health Leadership in Action, brought to you by Northeast Ohio Medical University in partnership with University Hospitals. I'm Dr. John Langell, President of NeoMed. VITALS is a national forum for us to hear from leaders in healthcare who use the VITALS tools, value, innovation, technology, advocacy, leadership, and service to solve our nation's biggest healthcare problems and to improve healthcare access. Today, I'm delighted to bring to the stage Dr. James Kravec. Dr. Kravec is the Chief Clinical Officer for Mercy Health Systems in their Lorain and Youngstown markets. In that role, he serves as a Chief Physician Executive, overseeing over 1,500 physicians and advanced clinical providers, 5 hospitals, 2 medical groups, an integrated health system, and an accountable care organization. Dr. Kravec is also Mercy Bon Secours 48 Hospital System Director for Graduate Medical Education, shaping the educational landscape for large numbers of trainees across their entire platform. He also serves as the Director of Public Health for the Mahoning County Department of Public Health. He is a graduate of Northeast Ohio Medical University's class of 2002 and has been an advocate for the university, serving in numerous roles, including both Section Chief and the Division Chief of Internal Medicine and as President of the NeoMed Foundation. Please join me in welcoming to the stage Dr. James Kravec.
Good afternoon. Thank you for having me here today to speak with you. It's an honor to be back at NeoMed as an alumni and as a clinical faculty member. So it's nice to speak with those of you in the audience here live and those of you on the internet as well. It's also nice to be here the first week that we have medical students joining. So thank you for those of you who are here in person as well. I know remember the first year very well, and it's overwhelming. So thanks for taking some time to listen to us here today. So today I'm going to speak about the emerging role of the physician leader as a transformative executive. And as we go through, you'll see that as we think about the physician executive, which in the past we've called the CMO or the Chief Medical Officer, there's been changes over the past several years. There's been changes throughout the pandemic. But now that we're through the pandemic, there's even more changes coming with new technology and new methods of work. And so how is that CMO, how is that Chief Physician Executive, what kind of role do they play? What kind of part do they play in the healthcare of not just their patients, but also the healthcare system in their communities, in their states, and in the country? So as I look at this is what we think of in the old way of what a chief medical officer is. Herding cats, a futile attempt to control that which is inherently uncontrollable. And so we joke about all the time as our new students begin their first year of medical school, and we think about what it's like to have students who are used to being the top of their class in high school. They go to college in the top of their class, and they go to medical school, and they graduate medical school, they go to residency, and they're very smart, and they're used to getting the best grades and the best attention. And now you have only that caliber of people from training their entire career as people that you're overseeing. It sometimes can be very challenging, especially when those people may be leaders in their offices and leaders in their practices and leaders of the medical staff. Trying to attempt change is very difficult. And so that's kind of the historical view of what a chief medical officer has been and really attempts to do. So who am I? I was introduced earlier, but I'm an internal medicine physician, a hospice and palliative care physician. I've been a physician after graduating from NeoMed, formerly NeoUCOM, in 2002. I currently serve as the chief clinical officer of a large health system in Northeast Ohio with Bon Secours Mercy Health. I work and lead their graduate medical education, and I oversee the health department. So that's my part of what I do, but really the reality is I serve as the chief physician executive for the region of Northeast Ohio. And so I'm going to talk a little bit today, not about me, but about the roles of physician leaders, because as almost every physician that goes to medical school that ends up being a physician leader doesn't choose to be a physician leader when they started medical school in the first week of M1 school. Most people don't say, I want to be a chief clinical officer or a dean of a medical school or medical director of a health department. Most people say, I want to take care of patients, and things happen. That's what happens. And we'll talk about that in a little bit. So what's the alphabet soup of physician leadership? Really, and this is not talking about medical schools because it has its own terminology. I'm talking about physician leadership of health systems. There's a CCO as chief clinical officer, CMO as chief medical officer. Some hospitals have VPMA or VPSA, vice president of medical affairs, vice president of surgical affairs. There's simple medical directors of either hospitals or service lines or medical groups. Chief academic officers who tend to oversee students and residents and other learners. CMIO are the chief medical information officer, those that oversee our electronic medical record or other technology in hospitals as a physician. So that's the alphabet soup that you'll hear a lot about as we go through this presentation. So a chief medical officer or a vice president of medical affairs, depending on what hospital you work at, these can be seen as interchangeable. Some hospitals have both. About a quarter of hospitals have both. But for the most part, generally, CMOs or chief medical officers are at larger hospitals. Vice president of medical affairs are at smaller hospitals. Medical directors tend to be at tiny hospitals. That tends to be the generality. And how much time do the physician leaders spend? I spend a very little amount of my time in direct patient care. I still work with residents and students. I still see patients. Very little bit. I wish it was more, but that's the sacrifice that I've taken over my career. If you're in these roles of a chief medical officer or vice president of medical affairs, they can be split. I have 50-50 equals 80-80. What does that mean? That's probably, when I started, I was a medical director of a medical group. And those other physician leaders in the room probably know this. When you're a 50-50 employee, that's probably, in my opinion, the toughest split there can be. Because 50-50 means half your time clinical, half your time administrative. And the reality is, when you're clinical, there's always administrative things come up. And when you're administrative, there's always clinical things that come up. So 50-50 means you're 80-80. That's a really challenging role. It's a lot easier when you're 90% administrative, 10% clinical, or even the other way around, because you can control your time a little better. It's also challenging if you're multiple employers. If you're employed by the emergency medicine group and you work for the hospital, that's hard. Not impossible, but it's hard. Most physician leaders are employed by the hospital as a clinician and as a leader. So those are just some practical things that it's nice to learn about. The traditional CMO, right? So this is the CMO of not even decades and decades ago, but of maybe 10 years ago and longer. The traditional chief medical officer tended to be in a role that wasn't well defined. Maybe it wasn't critical to the hospital. Sometimes those roles were cut in tough budget cycles. Usually it was part-time, usually a senior physician. Usually those folks worked by influence because they were a senior physician. They knew they had relationships with other physicians. They weren't well trained as a leader. They were well trained clinically. They may not have been well trained in their role as a physician leader. Again, they led by influence, trying to engage with their personality to get things done. Work with a camaraderie of physician peers. They were well liked, well respected. They saw a building, usually, not a health system or a network or a group with 50 offices, for example. They facilitated the work of the traditional medical staff, and they probably struggled mostly with physician behavior. Thought we started off with the cat analogy in the beginning. That is a challenge for physician leaders then and now. But this was the historical chief medical officer. But times have changed with physician leadership. As we think about the triple aim of healthcare, as we talk about the Accountable Care Act that happened a decade ago, as we think about what's changing in healthcare, the transformation calls for a transformative leader. So physicians, hospitals need alignment with the goals of safety, high reliable care. The physician leader needs to understand all levels of an organization, not just four walls of a hospital or a building. There's a structure. Do they understand the structure, how to work in a system? Most hospitals are not owned solely by that hospital in that small town. They're usually part of a bigger system. That's challenging sometimes. I'm willing to understand the rules, but also challenge the way it's always been done. But they still serve as a liaison between the physicians who see patients full time and then the executives who don't see patients at all. So that's challenging. But then you need to understand legal, finance, corporate audits, IT, all the Stark laws and anti-kickback laws, things that you're not learning yet in medical school. Most residents haven't learned, or at least if you learn it, you learn a very small part of it. And really be the physician leader as hospitals merge and there's acquisitions and growth. You're the physician leader. And with that comes responsibility and voice. So the CMO today is truly a transformative executive. NeoMed has talked about the transformative leaders for years, and this is one role that is so vital to the stability of health systems, to have a transformative physician leader. They lead culture change, the behavior change of physicians. How do we spearhead physician acceptance of all these new rules, case management? Hey, doctor, you need to discharge that patient because the insurance company has limits. We need beds for more patients. Focus on those goals. How do we coordinate utilization management, quality, and safety all together? Using less catheters, using less central lines, for example. Champion value-based care and reimbursement. We need to order more mammographies and make sure our blood pressures are better controlled and make sure that our hemoglobin A1Cs are better controlled so that we can have better reimbursement, so that we can buy more surgical robots and have more technology and new locations, because you need to have that money to be able to afford that. And that's how we're getting paid these days. What I would say probably in my role, one of the most time-consuming yet rewarding things I do is interviews. Between the Youngstown 3 hospitals and our Lorraine 2 hospitals, we probably hire about 100 new physicians every year. But I interview probably about 250 physicians every year. And I make a point to interview every single candidate that we have. It's a very, very important piece, I believe, for a candidate coming out of residency or out of private practice or moving from another hospital to understand what our culture is. And I want to make sure that I can talk to those candidates. But also, you are the graduate medical education executive. You may have someone overseeing the day-to-day work in the residency programs, but I find one of my major pieces of my time spent is working with our students and residents and making sure it's all coordinated. And how do we grow in that realm? This is a slide from Debbie Downer, and sometimes the Saturday Night Live skit is kind of what it feels like to be a chief medical officer when you're talking about all the new things. I'm the physician communicator in our community. It started with COVID and public health issues, but there's things like monkeypox and influenza flares and swine flu and the tomato virus. That put me over the top, I think, after COVID. We started talking about tomato virus one day. Oh, wow, So, we're talking about masking and vaccines. Thank goodness the masking part is over, but that was a big part of my communication several years ago. Then talking with new physicians about technology and talking about how we're going to have these communications. There's a strategy behind that, about how we're communicating, how often we're communicating. Do we text our doctors? Do we email them? Things that I know that the medical school deals with in working with communication as well. We deal with that with the physicians also. But there's a next level of expectation. So again, as I said, the chief medical officer of the past focused on influence, and they were the senior physician usually. Well, now we expect some sort of level of physician training in leadership. it's one thing to be trained as I was in internal medicine, or I learned hospice after I was an attending. I didn't go through a formal fellowship, but I went for boards and I went through practical education. That's one way to learn, but formal education in physician leadership is very, very important that most places haven't had before. But you're also providing the physician leadership to your medical directors and those that work with you. You're providing that leadership. Burnout awareness is a huge conversation now. Dealing with physician death by suicide is a very important cultural importance that we're talking about. We have these conversations with our medical staff and with our resident physicians, and it's my role as a physician executive to have those conversations. And then I coach and mentor, not just formally, but very informally, my medical directors and my other physician leaders to make sure that what we've set in place for them is really something that they can use and take it and teach their folks as well. Data and metrics is a major part of what I do. And it's hard to measure and expect outcomes if you don't set the data goals, and realizing the data is, bad data in is bad data out. I'm sure you've learned that. So making sure that we have the right metrics for these folks. I'm the electronic medical record champion, which is a very challenging part of the job, realizing that we need our physicians to use the electronic medical record, as that is a big part of what we do. The clinical documentation piece, making sure that insurance companies know how sick our patients are, and working with physician advisors, which are other physicians who are in leadership roles with insurance companies, calling our physicians saying, how can you document this better? How can we have more documentation to show how sick our patients are? Physician executive needs to understand compensation and how we pay our doctors, especially in the employed physician model, how we value work in the medical group, how we pay, how the Center for Medicare and Medicaid changes reimbursement. We need to understand legal things like Stark and anti-kickback and accountable care organizations, and how we can talk to physicians and use the information that the accountable care organization laws allow us to use. How many of you have heard about HIPAA, so Patient Privacy Acts, and how we can help manage and teach that, but also deal with breaches of HIPAA that we have periodically. There's audits that happen, unfortunately, but we have to deal with that. And then there's the medical technology, because almost every physician that we interview says, well, I need this device or this machine, and it helps patients. But we have to determine, well, is it too expensive? Is it reimbursable? Is it really helping a patient? Is there evidence behind that? And so that's kind of part of what I do, is realizing that we have to analyze the technology, and using that technology will help us understand, can we afford it, and will it help patients? And then as I wrap up my section of the new age physician leader is behavioral modification, and realizing that you must have culture change without absolute authority. As you're in medical school, there is absolute authority because you're a student, and if you have a behavior problem or a grade problem, there's an absolute authority above you, which is the dean or your chair. If you're in residency, there is an absolute authority. There's a designated institutional official, and there's rules, and there's a program director. When you're on medical staff in a hospital, sometimes there's not as absolute authority with the chief medical officer. There's a lot of bylaw rules, there's a lot of appeal processes and the like that make it harder to, so it's a lot of managing by influencing, having the exceptional interpersonal skills, communication skills, and gaining the trust. As I onboard a new chief medical officer, and I did that about 6 months ago, the number one goal for that person in his first 6 months in this job is to gain trust from the medical staff. Without the trust, talking about how much C. diff is ordered and how many catheters are used is worthless, because you have to gain that trust. You need to affect the change without too heavy of a hand, because if you come in too hard, when you need the help of catheters and length of stay and moving patients through the system, some of the physicians won't listen if you come in with too heavy a hand. So it's a really challenging, but that's what we do. So the summary of the role is this. This is how I took the last few slides and put it together into these 4 buckets. Clinical operations, case management and throughput, medical staff relationships, and hospital clinical strategy. So how many tests are ordered, all the quality metrics, that's clinical operations. case management and throughput, working with our nurse managers and our case managers, getting patients through the system, in the hospital, out of the hospital. Focusing on medical staff relationships, such as behavior issues, as I talked about, working with the officers of medical staff and the chairpersons, and getting new doctors on staff through credentialing. And then working as the chief physician executive, working with finance, legal, strategy, building new hospitals, building new clinics, getting new equipment. So that's really a summary of the 4 areas. And if you do it right, this is what it looks like. So it went from the Cats to leading a symphony as the conductor. And that's really what the physician leaders of today need to be. They need to be the conductor of the orchestra that is the medical staff. You know, if I look at my role, I have 1,500 physicians that I help oversee between Lorraine, Oberlin, Youngstown, Warren, and Boardman. And when you think about that, there's so many personalities and there's so many different ways, but it has to work as an orchestra. So at this point, I thank you for your time. We're going to begin a question and answer, and I'd like to welcome Monica Robbins of Channel 3 News in Cleveland to join me.
Thank you, Dr. Kravec. So nice to see you. And it's so nice to see everybody in our live audience. I'm curious, though, of everyone here, how many of you think you could run a hospital? Not one hand. Interesting. You talked a lot about CMO, and you also talked about chief clinical officer. Is there a difference?
So the chief clinical officer is a term that was, I guess I'll say, was invented about 6 or 7 years ago. The chief clinical officer tends to be the synonym is the chief physician executive. So as a chief clinical officer, it's not about a building, it's more about a health system and looking at patients and care sites of all of the hospitals in your area, but also the network, which is your accountable care organization, your associate health plan, your medical group practices, and the medical staff. So the chief clinical officer tends to be the chief physician executive, not over a building, but over the entire breadth of what we do in healthcare in 2024.
I want to encourage all of our Zoom watchers here. There is a Q&A section. If you have any questions for Dr. Kravec, please put your questions in the Q&A section. Also, all of our live audience folks, we have a microphone right in the center. If you have any questions, please make your way right up to the mic. Jonathan is turning it on for you. So from an organizational standpoint, I'm curious to know, when you were here at NeoMed in 2002, was there ever a moment that you felt that you had that leadership ability, or when was that moment that you realized that you were the guy who could lead a hospital system?
You know, so I was at NeoMed from 1998 to 2002. And when I was here, and for those students that are starting, I mean, I think the most important thing you need to do, if you do think you want to be a hospital executive or you want to be in leadership, even at a department level or medical practice level, the most important thing you need to do your first year of medical school is study your classes and your biochemistry and your labs and microbiology and anatomy. That has to be the number one, 100% of your focus. The rest of the stuff will not come ever if you're not a great clinical physician. And that is the most important thing you need to do. And it will remain the number one thing you have to do during all of medical school and all of residency. You have to pass your boards. You have to get good grades in your classes. You have to excel. And you have to have the knowledge, most importantly, to care for your patients. So that's the number one thing we have to do. And that's what I would say to our new students: you have to do well in class, take care of your patients first and foremost. But if you want to do well in leadership roles, you have to be a great clinician first. So I never aspired to that. When I was here, though, I took on some leadership roles of a group. I helped with my best friend, who was another student. We started the Catholic Medical Association of Catholic Medical Students, which is a group on campus. We started involved in other groups as well. I was involved in the student council group, by getting involved and doing some events and helping with things. So I did other things to help. And as you went from M1 to M2, primarily because you're on this campus, I was involved in leadership of some of those events and groups. That's important. But the number one focus was always that. Now, it changed over time. As you become a resident, there's resident councils. As you become a young attending, you're learning more as a young attending than you were as a young medical student. So you got to focus on that. But that's how it started.
But leadership roles were never something you actually sought after until later in your career?
Yeah, the first time I had a formal leadership role was when I decided to run for an election of chairman of internal medicine at St. Elizabeth Youngstown Hospital, and it was kind of one of those where like everyone puts their hand up and everyone steps back. Most people don't want to be a chairman of a department in a hospital. I mean, we're a level 1 trauma center, but even that, it's not like it's at a major academic institution where it's a full-time job. As a chairman in a hospital in a community setting, it's not many people want to do that. That was my first official role. And then I transitioned literally with, I think I must have done a decent job, because about 2 years later, it was literally a tap on the shoulder by my CEO of the hospital in the cafeteria line. And he said, "Hey, can we have lunch?" And the conversation was, can you do a 50-50 role of leading the medical group and still practicing? So that's how that started for me, at least.
We have a question from one of our Zoom watchers. This is, I'm going to ask you for the list or the top 10, because this question is great. What is the most stressful part of running an entire hospital?
I think the biggest part, I think the clinical stuff is easy, meaning I can talk to physicians about you shouldn't order C. diff when you don't need to. You need to get length of stay out. But when we have to couple that with reimbursement changes and the fact that the budget does matter, right? It's easy to always do the right thing and order new equipment and replace that carpet that needs replaced. It's easy to do that. It's easy to know what to do, I should say. Then we have to figure out how we can afford things like that and how we can afford the new machine that is going to help patients, but we got to pay for it. And the margins are so tight. If you look at a grocery store, you look at a restaurant, we expect to make a profit. That's okay. Those profit margins are greater than what you see in a hospital system, which historically had been like 3%. Now they're at negative or 0.1%. And so you can only spend what you make a profit on. And there's very little profit these days. That's the most challenging part for me right now.
Considering burnout, we're starting to see it level off, but there's still such a huge level of burnout. How are you dealing with that? How are you, giving respite to your physicians?
That's challenging. And so with burnout, we have to talk about it first. I think the medical school talks about it now. The residency programs talk about it now. We talk about it now. We need to have access. So in my health system with Bonsall Mercy Health, we have a way for our physicians, our clinical staff, our nurses to be able to call a friend. And we have it called Caring for Colleagues. So we set that program up so they can call and talk to a psychiatrist or psychologist that we have confidentially, quietly, no cost. And we have to identify it. We have to look for it. We have to teach about it, talk about it, and give it something that they can do to help.
I have a question.
Artificial intelligence. From your leadership role in a very large health system, where do you stand, or what are you doing for artificial intelligence, Chat GPT, things like that we're having to deal with here at NeoMed and across higher education?
So it started about 3 years ago. We have a system that, as when someone comes to the emergency department and they get a lot of CAT scans, a CAT scan of the brain, and if you're looking for blood for a bleed, right? But you're also looking maybe for abdominal problem, or you're looking for something else in the chest. We have a program that checks for blood in the brain, and if they find that, it immediately goes to the top of the list and it's read right away. So that was my first introduction of AI in healthcare. Is the radiology department is able to find blood immediately. The computer is able to find blood immediately, and it goes right to the top of the list, and we can read it rather than wait in a list that might be random. That was one example. Now we're talking about how do we use artificial intelligence in our medical practice. So as we have our cell phone, there's things called scribes, and there's dictation systems that we all have. But now you have your cell phone. You put it on the counter. You go to an app, and as I have my conversation with the patient, the entire note's being transcribed as we go, and not verbatim, but really in a way that we could have a note that's readable in the medical jargon and in the right format. So that's what I'm most excited about now. The primary care physicians that are using it in our pilot say it's the most life-changing thing that they've experienced, because all the time documenting is shrunk by a lot.
not making mistakes, though?
Yeah, you have to check it, but for the most part, it's been accurate, which is good.
Hi, Amy Lee, class of '88. So welcome
Wonderful.
back.
Yes, thank you.
I am teaching a class called Health Systems, and it didn't exist when you and I went to school. And one of the hard parts to reconcile is the textbook of health systems and how quickly some of the concepts probably become obsolete versus what's going on now. And so my question actually is, what are some of the more exciting developments that you see in the health system that are especially quickly evolving as you're a leader in a health system?
So the health system has changed so much. I'm in my master's of business administration program now. What we're learning now is almost obsolete. Same as what you're
Right.
experiencing. And so I think as we look at the technology and the way, we have some surgeons in the room, the way that surgery can happen so quick now with robotic. It was open to laparoscopic, and now the robotic surgery has just changed so dramatically. As I see what the students are able to learn now versus what I learned 20 years ago, it's dramatic. As I look at primary care, which may not be as exciting as surgery, in the technology world, as I look at the ways that we can assure that colonoscopies are done by using technology and DNA samples. Not as good right now, but I can almost bet it's going to be better in a few years, being able to know. So that's the biggest excitement I have when I look at health system is, the plain. If I look at weight loss medicines, for example, as I said, I don't see patients full time. So when I do see patients, I have to do a lot more reading about new medicines and whatnot. And the new diabetic drugs, the new weight loss drugs are so they're just changed, and their outcomes are so good. But there's so much more to come. So I think those are some of it's the technology for me, and both in medications and in machinery that is so exciting for me.
Great, thank you.
Thanks.
We have another question from our Zoom participants. On the topic of burnout specific to residents, do you or will you have training for physician educators or attendings on how to better work with residents and recognizing signs of burnout in the residents? She sees more and more stories on social media on residents and increased risk of suicide as a result of complete exhaustion and mental burnout.
In 2019, the greater Mahoning Valley area, which is Columbiana, Mahoning, and Trumbull County, had 4 physician suicides in 1 year. And that really opened everyone's eyes. We've heard about it, but it didn't hit home for us. So we've done a lot of conversation, a lot of teaching. I think we can do better, but we talk about it in our residency programs. We talked about it in our orientation of our new residents because it's something that is real. And I think having that teaching, having the programs, letting our faculty members know that we need to be on the alert for it, because there are signs. And I've had conversations with our chief academic officers about, this is something we have to watch with this individual. How do we have these conversations? Because I'm worried about it. So I think that probably, to answer the question, the most important area is being aware of it, having conversations, and having structured programs to help refer patients or physicians and residents to.
Is there a specialty that's most at risk?
You read studies that some specialties are more than others, but I think my experience, it's medicine. It's being a physician is very challenging these days.
All right, we have another question.
Hi, I'm Louis Gentile. I'm an incoming student this year. So as students, and especially here at NeoMed, we're taught to be, advocates for specifically underdeserved populations. I'm coming from Youngstown myself, so I know these communities. How can students connect with leaders like yourself or get in touch with leaders like yourself outside of the classroom to work on these issues? What advice do you have for us to connect, not just on a school level, but on our own?
I think as I said, the most important thing you can do is study, right? That's the first thing. But the second most important thing is to build relationships. Because I think as you think about physician leadership, you have to have that knowledge, but you have to have relationships. So, I know NeoMed does great programs, working with the teams of heading to the hospitals and meeting physician leaders. There's opportunities in the hospitals to do, summer programs and research opportunities. Connecting with alumni, working with the alumni office and finding people. That's probably one of the best ways to do it, because the faculty and the attending physicians are hungry to talk to students. The work we do does exactly what you said. We take care of the poor and underserved, and we open up access for those patients. So I think having those ways to get a hold of us, either through formal events that NeoMed puts on, or that the hospital puts on, or just by reaching out and calling us. Usually most people are open to that. It's not getting our emails or whatever. And I joke that my cell phone's on every wall in a bathroom stall because I get called by all the physicians. So call me directly. I don't care. That's what I would say is have the conversation, because that's how you make connections. And when you make those connections, you can do great work by helping the community and building more relationships and gathering more people, just to do our work together. Thank you.
What would you like to see medical schools do to help encourage more physicians going into leadership? Is there, classes you would like to see maybe in third year?
I think being able to so first of all, every physician is a leader. So I have a formal physician title as chief clinical officer. But if you choose to be a family medicine physician in an office that you own, for example, you're the physician leader. If you work for a hospital system and you are a physician in your practice, you're a leader. You're a leader of the care of the patients. You're a leader of your team. We work with team. That's very important to have a team, interdisciplinary teams. That's very important. The physician is a leader in all that she or he does. So I think knowing that, and as we go through our work, the leadership is what we do. So formal leadership is nice. It's nice to learn. That will continue to come over your career. But I think just acknowledging that you're the leader, knowing that your behavior always matters. I spoke to the incoming residents at Mercy Health in Youngstown and Boardman a few weeks ago. And I think this is probably the most important thing. To be a future leader, you are always on stage. As I look at our leaders of NeoMed, you can't go out on a Friday night and assume that your position doesn't matter and you're going to act crazy at a restaurant or driving a car or on social media. That's leadership, to know that as first-year medical students, you're always on. I use my air quotes of always on. In your role, you're always on. You can't assume that you're not affiliated with your news station at a restaurant.
Everywhere in the world.
Forever, and forever too, forever. So with that heavy responsibility comes the privilege of a good physician salary, of leadership roles, of respect. The ability to change jobs is a lot easier than other careers in America, but there's heavy responsibility. So I think the medical school, I'm sure it does, should continue to teach that we are always a leader. You're always a physician, no matter what you do, where you go, even on your personal time.
Yeah, and everybody's always watching.
Always.
Because cell phones are, everywhere.
I assume every email I write, every text I send privately, how will that look on the news, in the newspaper? During COVID, I probably, in the Youngstown market and nationally, I probably did about 300 news interviews. I had media training about a year before COVID, thank God, because it helped me. But I learned one mistake. I learned everything I say can be used in a good or bad way. One was bad, the rest were good. And I learned how to watch what I say. But you need to do that when you're texting, when you're on social media and Instagram and whatever you do, you are always a leader, you're always a physician, and you're always being watched. I don't mean that in a bad way, but that's just the way it is.
You have a question?
My daughter has been in hospice marketing for going on 20 years now. You probably know a little bit about what she's gone through. She's enjoyed it, and she still has her enthusiasm at what she has when she started in it. And I've had a lot of discussions with her and learned a lot about it. My mother was on hospice, so I saw it up close and personal. It's a wonderful program. It's too bad, in my view, why more people don't take advantage of it. But with your background in hospice, I'd be interested to hear your thoughts on what do you see for hospice in the future, and maybe some methods for getting more people to utilize it. I realize death is a tough subject, but what if any way to get more going?
Sure. So a question about hospice then is I've done about a decade of my career in hospice, and really hospice is underutilized. The data shows that hospice is, I forget the most recent numbers, but it's the average length of stay in a hospice is days to weeks, where it should be months, because patients are enrolled in hospice too late. I think the most important, education to the community is important. Education to physicians is very important. When I graduated NeoMed in 2002, not that long ago, we had 0 lectures on hospice or palliative care, 0. Now, several years later, it changed, but even that short ago. So think about As I look at myself as middle of career, anyone older than me had no formal training in hospice palliative care. That's probably why. Anyone younger than me did, because it changed about 2003 or so. So I think that's a big part of it, is working on teaching the physicians and teaching our nurse practitioners and physician assistants about hospice and the patients, because that's a big change. Now, nationally, talk about hospice, what's changed is previously most hospices were not-for-profit, owned by health systems. In the greater Youngstown market, there were two for decades. One was owned by Mercy Health, one was a private for-profit. Now there's 18 of them. One is owned by Mercy Health, and 17 of them are for-profit. So it's a business now as well. And that's not saying that's a bad thing, but it's been very diversified. There's a lot of small hospices in the country, a lot of small ones, less big ones, and less are owned by health systems. That's just the changing.
Speaking of that, do you think there's still a lot of education that needs to be done? Because I know a lot of patients will say they don't understand that the hospice doesn't mean death.
My favorite part of being a hospice physician is when patients graduated from hospice, and that happened. Not very few, but we've had patients that would no longer meet the criteria because they improved. Hospice doesn't mean death. Hospice means we're treating you, and we expect you. Wouldn't be surprised if you live 6 months or less. Patients survived. And it's also not just cancer. It's heart disease, it's lung disease, it's other issues that now the good part of that is in between hospice and traditional medical care is what we call palliative care. So we look at patients on those that are dealing with serious illness and whatnot. So that's another educational area for students these days.
Maybe we call it comfort care.
And comfort care is, we have called it that before. We're comfort and palliative together. Sometimes we call comfort care.
Right. We have another question.
Hello, my name is Mitchell. I just starting as an M1 here. So for me personally, my dad just recently went through the transition of being a physician as a pediatrician for many years to being, administrative role. And I've seen how that has affected his work-life balance. So how did that change for you, and how can you better adjust to that, going from your day-to-day as a physician to, attending more meetings, being on the phone all the time and all this other stuff?
Did it change it for the better or worse, or just different?
Both different.
Yeah. I want to see what your perspective was, because it's changed. I don't think it's better or worse. When I was a full-time clinical physician, I was on call every 5th or 6th night, and sometimes you'd come in. Most times I didn't have to go in. It was patients calling me for issues that for the most part I could handle, meaning my blood pressure is high, I give them medicine, the blood pressure goes down. They have acute appendicitis, I call a surgeon, surgeon takes care of it. That's kind of the stuff that I would handle. I don't want to say it was easy, but it's what I trained for 10 years. I would say now as an administrator, almost every single call I get is different. And I can't usually solve most of the problems immediately, and very low satisfaction of solving problems, because those are usually, they're bigger problems. Those administrators here at the medical school probably deal with that as well. You have an idea, and it's not going to be solved tomorrow. It's usually years, if ever, can you get to your goal. So that's one of my changes. Now that said, I feel like I have more control over my life. I have more evening phone calls and more evening meetings. They tend to be at home more, less going into the hospital, because I can control the phone calls and whatnot. So it's a plus minus. I would say it's probably the same amount of time. It's no less or no more, but it's more controlled. So for me personally, in a very selfish way, it helps me. I have 4 younger children. I usually am able to do what I need to do with my schedule. Whereas if I was seeing patients, my wife is a NeoMed grad as well. She's a full-time internal medicine physician. Her schedule's harder, to break away to an appointment for children's health care or whatnot, because she has 20 patients that half day. And I'm able to move something. And so from a selfish standpoint, it's a little more easy for me to manage, but there's different stresses and things that I wasn't trained in. Even though I had a lot of training, a lot of finance, a lot of legal stuff I wasn't trained in.
I want to remind our Zoom participants that they can put their questions in the Q&A. We still have about 10 minutes left. We have another question here.
Hi, my name's Alex. I'm also an incoming M1. There's been a lot of discourse, especially among people my age, about the rapidly increasing involvement of private equity in healthcare. And I'm curious, from your point of view in a leadership and administrative position, just sort of your general thoughts on how that has developed and what you think that looks like for the future.
Yeah, so private equity is now part of our world, and it's entered medicine, right? There's most large radiology groups in the country are owned by private equity. So many hospitalist groups, many emergency department groups are owned by private equity, gastroenterology groups, urology groups, ophthalmology groups. Even some insurance companies, which may or may not be considered private equity, but insurance companies will own hospital groups. You know, it's hard to serve multiple masters, right? So if you work for, example, if you work for Neomed, but you're trying to help a hospital, the reality is you're working for Neomed. If you're working for a hospital and you're trying to help Neomed, the reality is you're working for a hospital first. You can have different focuses, but it's hard to have multiple masters. So if you're a physician and you work for private equity, it's hard. You still want to help the patients, but you're controlled a lot by private equity. That's just what I see. And so that private equity wants profit because that's why the money was put into it in the first place. So it's hard. So I don't. Is it good or bad? It's different. It's challenging for health systems. For example, you know, if a health system that makes a profit of 1% or 0.5% or barely breaking even this year is contracting with a group that's owned by private equity, we're negotiating contracts. I get to do that these days. And as we do that, I know we might be at a 0.5% and we want to get to 0.6% margin. And they say, you need to raise our rates by triple. I said, we can't do that. We're at 0.1. We're trying to get to 0.2. We're at 0.4, trying to get 0.5. They said, no, we need to be at 30% profit. I said, but you got to understand, we're not at 30% profit. They said, we're going to be at 30% profit because our investors demand it. But we're going to be at 30% profit. And so I can say, no, and they leave, and I got to find someone else. Well, in some specialties that are all private equity, there's no one else to find because they're all private equity and they're all requiring 30 or 20 or 40% profit. So it's just changed the business of what we do. If you're employed by those groups, I'm not saying it's good or bad, it's just a different focus of what you have. And it's here now. Will it go away? Will it stay? I don't know, but it's here now.
What's your biggest physician complaint that you hear almost on a daily basis?
Biggest complaint I hear is the amount of time spent in the computer. So when you see a patient, that's the fun part of what we do. So, you know, my health system uses Epic. Most large health systems use Epic. I think the market share is 60 or 70% of the country in big systems. Seeing a patient is seeing a patient. But what I learned in the simulation center here is the same work I do now when I see patients. And I would scribble something that no one could read, and it was in a folder in a closet that was closed after 5 o'clock, right? It was terrible. Now it's accessible, but because it's accessible, it needs to make sense and it has to be done. And you also have volumes and volumes of information to go through. So physicians spend that much time preparing to see a patient, and you see the patient, that's the easy part. Then you have to document what you did and make sure you didn't miss anything that other physicians did. So my physicians will tell us all the time that's the most difficult part. Now, the question about artificial intelligence, that's the biggest hope they have for changing that. It's my biggest hope as well.
How would they change it for, you know, what a previous physician had done? Because they still have to look at the previous reports.
It changes the documentation piece. It changes the back end, not the front end. But over time, hopefully it'll all catch up.
And just give the high points, like the cliff notes.
Hopefully.
Okay. What about budgeting? Because right now what we're seeing in healthcare, you know, we've just seen our major institutions, they're cutting positions left and right. We're seeing layoffs after the pandemic, we saw, an income boost, for our hospitals. And now we're seeing things going the other way. Where's Mercy Health in this phase?
We're not for. So Mercy Health is part of Bon Secours Mercy Health. We're the 5th largest Catholic system in the country, the 11th largest system in the country. We haven't made a profit for several years. And you take away all the stimulus money that came through with the COVID money, I should say, there's no profit for about 4 years, 0. So when we need to buy a new piece of equipment, we need to buy a new site, we want to redo the floors, you need the air conditioners, all that stuff. We need money for that. And so as we say, we're not for profit, we have to make a profit because that's what you spend. Things are very tight. So we become very lean. For example, on spending community facing dollars, on having more leaders, having assistants and chiefs of staff, all the positions that we used to have in the hospital that were not core, either core leadership, like the leaders of the department, or patient facing. We've had to eliminate a lot of the frills that we had. And frills, I don't mean fun stuff, but I mean frills like assistants, and we're very lean. Now, that said, we're doing well. We still will add physicians. We are still adding nurses and all the clinical sites. We're still growing in market share in Northeast Ohio. So those are all positive, but we have to be very careful because it's very easy to teeter. If you act the old way, you're going to fail.
Final thoughts to our medical students. What would you like them to remember?
I think as you think about your either your first week at NeoMed, or you think about your career as a physician, we are all leaders. It's a journey to get there. And everything you say and do is part of who you are. So when you become a leader, you're using all those influences you've made, the relationships you've made, the knowledge you've learned here at NeoMed in your residency and your career to shape who you are. And that's how you become the best leader you can be.
All right. Thank you so much, Dr. Kravec. Can you give it up? Give it a hand. Hand it back over to Dr. Langell.
Thank you, Monica, as always, for your expert moderation. We truly appreciate your participation in Vitals. Dr. Kravec, thank you for a really outstanding and insightful conversation about leadership in healthcare. Please join us next month when we continue Vitals and hear from the next outstanding leader trying to transform healthcare for our communities. Until then, stay active and engaged and be a champion for our patient and our communities. Thank you.
This is VITALS, Visionary Health Leadership in Action.